Hello friends, today we are going to discuss about the traumatic brain injury. So injury from the traumatic brain injury is commonly divided into two subtypes. Primary injury is the dealt directly to the injury by initial insult and can be modified by the prevention. Much of the pre-hospital emergency department and ICU care has long been targeted at reducing secondary injury, which affect up to 91% of the traumatic brain injury. Then hypotension, hypoxia, and hemorrhage, intracranial hypertension, cerebral edema, and seizure, metabolic derangement all contribute to the secondary injury. The pathophysiology of the secondary brain injury. So there will be the first primary head injury, which occurred in the form of the initial insult to the head, which results into the tissue damage. It may result into the contusion, damage to the blood vessels, and axonal sharing that lead to the edema and swelling, which causes the inflammatory response and the increased capillary permeability within the brain, which leads to the increased ICP. Now, because of the increased ICP, there will be the cerebral vasoconstriction, which will lead to cerebral ischemia and then is increased systemic vasoconstriction. Now, when this ICP will initially when this ICP whenever this ICP will increase, the body will try to make the compensatory changes. But when the ICP when this rise in ICP will enter into the decompensated phase, then it will start approaching the mean arterial pressure, which will lead to the edema, swelling, and increase blood flow to the brain, uh, which causes the decrease in the cerebral perfusion pressure, severe cerebral ischemia, brain herniation, and finally brain. So, regarding diagnosis, the mainstay of the urgent neuroimaging remains the computed tomography. Although magnetic resonance imaging is more sensitive for the axonal injury, small hemorrhage, acute ischemia, and visualization of the brainstem and the posterior fossa structure. The CT acute SAH and rapidly shows the large hemorrhage and large subacute infarct. So CT angiography, less commonly CT venography, are also utilized to investigate the suspected concomitant vascular injury, and CT scanning is also done in the context of polytrauma to visualize extracranial injuries in the chest, abdomen, and the pelvis. So as we have understood from the pathophysiology, the main cause of mortality or illness, which is occurred because of the traumatic brain injury, is because of the raised IC. So the management of the traumatic brain injury is revolves around this raised IC and measures to reduce this. So it divides into the tier 0, tier 1, tier 2, and tier 3. Tier 0 includes ICU admission, intubation, mechanical ventilation, central and arterial line insertion, ETCO2 monitoring, ICP monitoring, and venous return optimization. Then serial clinical evaluation. Analgesia and sedation for comfort and mechanical ventilation. Then avoidance of pyrexia and hyponatremia. Saturation should be more than or equal to 94%, and cerebral perfusion pressure should be more than or equal to 60 mmHg. Hemoglobin should be more than 7 and consider anti-epileptic prophylaxis. Tier 1 includes cerebral perfusion pressure of 60 to 70, analgesia and sedation for ICP control, PaCO2 between 35 to 38, bolus hyperosmolar therapy in the form of mannitol and hypertonic saline up to maintain the sodium of 155 and serum osmolarity of 320. Then CSF drainage by EVD and consider anti-seizure prophylaxis and EEG monitoring. Then tier 2 includes mild hypocapnia, that is PaCO2 of 32 to 35. Consider trial dose of neuromuscular blocking agent. If effective, proceed with the continuous infusion. Ensure adequate sedation, assessment of cerebral autoregulation, MAP challenge, and CPP adjustment. Then tier 3 include barbiturate coma, hypothermia, and secondary decompressive cranial. Then how to monitor IC. Management of severe traumatic brain injury patient using information from the ICP monitoring is recommended to reduce in-hospital and 2-week post-injury mortality. So ICP should be monitored in all salvageable patients with traumatic brain injury, those who have the GCS score of 3 to 8 after resuscitation and who have presented with the abnormal CT scan. The abnormal CT scan of the head is one that reveals hematoma, contusion, swelling, herniation, and compressed basal system. So CT monitoring is also recommended in patients with severe traumatic brain injury with normal CT scan if more of the two of the following features are noted at admission. Like if age is more than 40 years, unilateral bilateral motor posturing, systolic blood pressure less than 90. So management of severe traumatic brain injury patient using guideline-based recommendation for CPP monitoring is recommended to decrease 2-week mortality. Then jugular bulb monitoring of the AVDO2 as a source of information for a management decision may be considered to reduce mortality and improve outcome at 3 and 6 month post-injury. Then regarding blood pressure target. Systolic blood pressure is maintained over 100 mmHg for those aged 50 to 69 years, over 110 mmHg for those 15 to 49 years, and over 70 years. Management to maintain adequate CPP improves the outcome. Then about the fluids and traumatic brain injury. Isotonic fluid remain the primary vehicle for volume resuscitation. Mannitol is effective for control of raised ICP at the dose of 0.25 to 1 gram per kg of body. Arterial hypotension, that is systolic blood pressure of less than 90 mmHg should be avoided. Hyponatremic and hypoosmotic fluid will induce and exacerbate cerebral edema and are avoided during resuscitation and throughout the critical phase of traumatic brain injury, even when hypernatremia is present. So hypertonic saline solution, including 23.4% saline, may be used in place of mannitol during trauma resuscitation and may have slightly more sustained effect and improve outcome. An advantage favoring hypertonic saline is that it acts as volume expander, whereas mannitol will act as osmotic diuretic, possibly reducing the effectiveness of volume resuscitation, and is not used judiciously can result in complication from hypovolemia such as renal failure, electrolyte abnormalities, and rarely pulmonary edema. So regarding seizure management, seizure may increase the ICP and it may lead to secondary injury. So prophylactic use of phenytoin and valproate is not recommended for preventing late post-traumatic seizure. Phenytoin is recommended to decrease the incidence of early post-traumatic seizure, that is within 7 days, when overall benefit is thought to outweigh the complication associated with such a treatment. However, early post-traumatic seizure have not been associated with worse outcome. At present, there is insufficient evidence to recommend it levetiracetam compared with phenytoin regarding efficacy in preventing early post-traumatic seizure and toxicity. Now regarding cerebrospinal fluid drainage. An EVD system zeroed at midbrain with continuous drainage of CSF may be considered to lower ICP burden more effectively than the intermittent use. Use of CSF drainage to lower ICP in patients with initial GCS of less than 6 during first 12 hours after injury may be considered. Now regarding reversal of anticoagulation. Reversal of anticoagulation must be performed promptly after traumatic brain injury patient with intracranial hemorrhage. Among patients receiving vitamin K antagonist with INR over 1.4, vitamin K 10 mg IV should be given conventionally, followed on day 2 and day 3 by 5 to 10 mg enter. Reversal of anticoagulation with 4-factor prothrombin complex concentrate dose by weight and INR is faster and superior to plasma transfusion. Kcentra is the PCC, which is FDA approved for warfarin reversal among patients with major bleeding and requiring urgent surgery. For patients with history of heparin-induced thrombocytopenia in past 90 days, plasma transfusion and factor 7A dosing may be considered because Kcentra contains the small amount of heparin. The anticoagulant effect of direct thrombin inhibitor, that is dabigatran, can be reversed by FDA-approved reversal agent, that is adarisuzumab, which bind and inactivates dabigatran. If adarisuzumab is not available, then Kcentra, hemodialysis, and hemofiltration have been attempted. Adexanet alpha is the chemical antidote to reverse the direct factor 10A inhibitors such as apixaban and rivaroxaban, among others, and reverses the anticoagulant effect of this drug. For patients receiving aspirin, platelet transfusion must be considered for those requiring urgent neurosurgery. Transfusion is not useful for patients receiving glycoprotein 2B3A inhibitors as transfused platelets are inactivated through though salvage transfusion is often considered. The current evidences does not support the use of platelet transfusion for patients who are on the antiplatelet drugs. Now regarding mechanical ventilator management. Hypoxia and hypercarbia may exacerbate secondary injury and complicate ICP and CCP management. So the Brain Trauma Foundation recommended maintaining SpO2 over 90% and PaO2 over 60 for traumatic brain injury patients. Advanced mode of mechanical ventilation and inotropic or vasopressor treatment are frequently required to maintain CPP and adequate gas exchange. For some patients, hypoxia may be resistant to conventional ventilatory setting and increase in oxygenation may be required. So concern has been raised over the effect of PEEP on ICP. So the published data, however, reveal varying effect of PEEP on ICP. One theory states that the PEEP raises the intrathoracic pressure, thus decreasing venous return to chest and thus increasing volume of venous blood inside the cranial vault will cause the rise in ICP. In reality, it is unclear to what extent the change of PEEP are transmitted into thoracic cavity, much less into vascular system, where venous return could be affected, especially among patients with acute respiratory distress syndrome, where stiffness of diseased lung may not transmit the PEEP effectively. A series of traumatic brain injury patients with acute lung injury and ARDS reported that ICP was more tightly associated with PaCO2 than the level of P. For refractory hypoxia, prone positioning has been reported in several series. Although in some neurocritical care series, raised ICP has been reported, in dedicated series of traumatic brain injury patients with ARDS, prone positioning was associated with improved oxygenation without detrimental effect on ICP or CCP. So ventilation of traumatic brain injury demands attention to systemic acid-base balance to secondary effect on cerebral blood. Now regarding surgical therapies for traumatic brain injury. Surgical hematoma evacuation is commonly performed acutely for subdural hematoma over 1 centimeter in width and epidural hematomas with significant mass effect or progression. So routine evacuation of parenchymal hemorrhage is not indicated as violation of otherwise healthy and recoverable tissue may be required to access the hematoma. However, intracranial hypertension refractory to medical management may be an indication for resection of parenchymal hematoma. So decompressive craniotomy has historically been viewed as a last resort for management of traumatic brain injury with intracranial hypertension. And one complication of decompressive craniotomy is injury to the brain tissue, blood vessels, especially vein at the edges of craniotomy defect. And the authors recommended the removal of at least 12 centimeter diameter bone flap, and extension of craniotomy to temporal bone is also sometimes recommended. The retrospective review of traumatic brain injury patient treated with decompressive craniotomy found no outcome benefit compared to the historical control. So, according to the Brain Trauma Foundation guideline, bifrontal decompressive craniotomy is not recommended to improve outcome as measured by GOSE score at 6 months post-injury in severe traumatic brain injury patient with diffuse injury and with ICP elevation to values more than 20 mmHg for more than 15 minutes within 1 hour period that are refractory to the first tier therapies. However, this procedure has been demonstrated to reduce ICP and to minimize days in the ICU. A large frontotemporal temporoparietal decompressive craniotomy is recommended over small frontotemporal parietal decompressive craniotomy for reduced mortality and improved neurological outcome in patients with severe traumatic brain injury. So these are the studies which are published in context of traumatic brain injury. So first is a EPO-TBI study. According to this study, the use of erythropoietin compared to placebo did not improve overall long-term outcome and quality of life in patients with moderate or severe traumatic brain injury and in any of the priority defined subgroup. Now, regarding in the context of decompressive craniotomy, the DECRA trial and rescue trial was published. According to DECRA trial, in a patient with the severe diffuse traumatic brain injury and refractory intracranial hypertension, early bifrontotemporoparietal decompressive craniotomy decreased the intracranial pressure and length of stay in ICU, but was associated with more unfavorable outcomes. Now, regarding rescue trial at 6 months, decompressive craniotomy in patients with traumatic brain injury and refractory intracranial hypertension resulted in lower mortality and higher rate of vegetative state, lower severe disability, and upper severe disability than the medical care. Now, according to Best Strip trial, for patients with severe traumatic brain injury, care is focused on maintaining monitored intracranial pressure at 20 mmHg or less, was not shown to be superior to care based on imaging and clinical examination. Now, regarding prophylactic hypothermia, early that is within 2.5 hours and short term that is within 48 hours. Prophylactic hypothermia is not recommended to improve outcome in patient with diffuse injury. So regarding this, there are two trials, that is Eurotherm trial and POLAR-ACT trial. In Eurotherm trial, in patient with the intracranial pressure of more than 20 mmHg after traumatic brain injury, therapeutic hypothermia plus standard care to reduce intracranial pressure did not result in outcome better than those with standard care alone. Now, according to the POLAR-ACT trial, hypothermia did not improve 6-month outcome. Hypothermia increases the incidence of pneumonia, ventilation days, and noradrenaline use and bradycardia. Now, regarding hyperventilation, therapeutic hyperventilation is the fastest way to lower ICP, which by causing rapid vasoconstriction of cerebral arterial supply. The animal experiments and human observation reveal that hyperventilation causes decrease in partial pressure of oxygen in brain tissue, and hyperventilation is now contraindicated during acute phase of traumatic brain injury and is discouraged by most of the authorities. Even for normal brain tissue, decrease of PaCO2 below 30 mmHg resulted in decreased cerebral blood flow and evidence of anaerobic metabolism. Although evidence of harm with less aggressive hyperventilation is lacking, evidence for its benefit is absent. If used when other measures fail, hyperventilation should be monitored with one of the marker for tissue stress such as brain tissue oximetry and microtests. Now, according to Brain Trauma Foundation guideline, prolonged prophylactic hyperventilation with PaCO2 of less than or equal to 25 mmHg is not recommended. Hyperventilation should be avoided during first 24 hours after injury when cerebral blood flow often is reduced critical. If hyperventilation is used, then SgO2 and BPTO2 measurements are recommended to monitor oxygen delivery. Then about barbiturate coma. Administration of barbiturate to induce burst suppression measured by EEG as prophylaxis against development of intracranial hypertension is not recommended. High-dose barbiturate administration is recommended to control elevated ICP refractory to maximum standard medical or surgical treatment. Hemodynamic stability is essential before and during barbiturate therapy. Now, regarding steroid, the use of steroid is not recommended for improving outcome or reducing ICP. In patients with severe traumatic LT and it is contracted. Now, about the and basal caloric replacement at least by fifth day or at most by seventh day post injury is recommended to decrease the mortality. Transgastric jejunal feeding is recommended to reduce the incidence of ventilator associated pneumonia. Now about infection prophylaxis. Early tracheostomy is recommended to reduce mechanical ventilation days when overall benefit is thought to outweigh the complications associated with such a procedure. However, there is no evidence that early tracheostomy reduces mortality or rate of nosocomial pneumonia. The use of oral care is not recommended to reduce the ventilator-associated pneumonia and may cause increased risk of acute respiratory distress syndrome. Then antimicrobial impregnated catheter may be considered to prevent catheter-related infection during external ventricular drainage. Now about deep vein thrombosis prophylaxis. LMWH and low-dose unfractionated heparin may be used in combination with mechanical prophylaxis. However, there is increased risk of expansion of intracranial hemorrhage. In addition to compression stocking, pharmacological prophylaxis may be considered if brain injury is stable and the benefit is considered to outweigh the risk of increased intracranial hemorrhage. There is insufficient evidence to support recommendations regarding the preferred agent, dose, and timing of pharmacological prophylaxis for deep vein thrombosis. Now, about the management of ARDS when the patient is having traumatic brain injury. So, the problem with the patient with traumatic brain injury is, along with the patient with ARDS, is in the mechanical ventilation of the ARDS. Because in the while managing ARDS, we are accepting the we are always following the lung protection, lung protective mechanical ventilation, which consists of low tidal volume. So whenever we are keeping the tidal volume low, the PCO2 is rising, and this rise in PCO2 is harmful for the brain injury. Now the second point is PEEP. So while managing ARDS, we are keeping the PEEP in the high position. But if we set this high PEEP, then it will cause the increase in IC. Therefore, the management of ARDS in setting of traumatic brain injury is challenge, or management of the, or we can say vice versa. So the solution of this problem is if the ARDS is mild, then no need to worry about the traumatic brain injury. We can follow the lung protective mechanical ventilation. So in this setting, the clinician should in first instance optimize the ventilatory setting, in particular increasing PEEP to improve oxygenation or increasing tidal volume and respiratory rate in order to achieve partial pressure of carbon dioxide target. If necessary, we can give the neuromuscular blocking agent. Hypothermia, barbiturate, decompressive craniotomy should still taken into consideration in case of refractory intracranial hypertension. But in case of moderate ARDS, in addition to previous strategy, we can add neuromuscular blocking agent. And we can consider the early prone position if there is a failure of tier 1 and tier 2 strategies. But or we can go for the and if after following all these measures still the patient is hypoxemic, we can explore the option of ECMO. But if the patient is in severe ARDS, then we should follow the lung protective mechanism. Then we should strictly go with the lung protective mechanical ventilation. So and in that case give priority to give priority to that condition which is life threatening. What I meant to say is, if traumatic brain injury is life threatening, then manage traumatic brain injury, and if ARDS is life threatening, then go for the management of the ARDS properly. So even if we follow the lung protective mechanical ventilation, and by after following the and after keeping the low tidal volume, if PCO2 is rise, then accept that PCO2, accept that permissive hypercapnia, or we can set the high PEEP, even because the high PEEP won't cause directly. There is no evidence that high PEEP will cause direct increase in IC. Thank you, guys.